Before we dive in, I want to give huge shout outs to community partners Epilepsy Foundation of America, the Danny Did Foundation, and Epilepsy Alliance America. And big thanks to sponsors Neurelis and SK Life Science. Thank you for believing in this podcast and to help keep it going. All right, y'all, pull up a seat. This is going to be good. Hey guys, welcome to What the F. Thank you so much for tuning in. I really appreciate it. And if you guys want to help keep this podcast going, please make sure that you subscribe, comment, leave a review on whatever platform you're listening to, whatever that's Spotify, Apple, or YouTube. Really appreciate that. And make sure to catch up on new content on our Instagram at What the F Podcast. So today's guest is someone who I have talked about internally with myself having on the show for a long time. And at one point I even said, I'm coming for you. Get ready, because it's going to happen. Today's guest is Ayesha Akhtar, who is the Vice President of Health Equity, Education, and Advocacy at the Epilepsy Foundation of Greater Chicago. Ayesha, thank you so much for being here.
Thank you. I made it.
Yeah,
we're here.
I know. And so many people were like, when are you going to have Ayesha on? And I was like, don't you worry. It's coming.
That's great. You planted the seed a while ago.
Oh, for sure. Yes. And so I'm so stoked to have you here.
You.
And I just want to start with, I know we're going to tackle a lot in this episode, talking about health equity, and like what that means. And then also the two projects that you are spearheading right now that have the potential to be like, a platform, not a platform, but like a pilot or an example that could be integrated into other places all over. But first, I just really want to focus on health equity because I feel like it's a term that gets thrown around a lot. And I don't know if we always stop to think about what it means.
Yeah.
And when you and I spoke a while ago, I loved your definition of health equity.
Yeah. Yeah, I love this because it's a good opportunity to just pause and just really look at the world a different way. So I rebranded our education department to have the term health equity in front of education a couple of years ago. And that was to be very intentional about the people we're serving. Because health equity to me, so healthcare to me is a human right. And if you believe healthcare is a human right, you're already on the journey through that I'm on, basically. And so health equity, the way I see it, is not like we're doing anything different. It's not a technique. It's not a destination. It's how we do the work. It's putting on a pair of lenses that are the health equity lenses. And that's how we see the world. And I'm sure a lot of people have seen that graphic of three people looking over a fence, and you have equality, equity, and justice. So equity is making sure that everyone has a fair, equal opportunity to have everything that everyone else can have. So when it's coming to the conversation of healthcare, everyone has access. And so that's what I really wanted to look at. So Epilepsy Foundation of Greater Chicago is an affiliate of the national organization. And so in our affiliate agreement, we are responsible to serve 44 counties. Now we have a great seat in Chicago.
Yeah.
We like right off the loop.
Right. But can we pause?
Yeah.
44 counties.
Yes.
Because I do feel like, and I'm sure you feel this way too, like when it says Greater Chicago, it just sounds more Chicago based.
Yeah.
And like you said, you guys, the office is amazing. It's on State Street. Like,
Awesome.
Come on.
Yeah.
So it is Chicago based, but that is 44 counties.
Huge.
Is huge.
Yeah. And I'm not going to 44 counties, and our team is not going.
Yeah.
So it's a tall order.
Mm-hmm.
And so I really wanted us to look critically at how are we serving the rest of the community that we're supposed to be serving, and not even just supposed to be, but like need access to care.
Yes.
And so to be very intentional about who we serve and how we reach people is my goal. And so those are the projects that we were talking about, the Community Health Worker Program.
Yeah. And let's start with that one.
Yeah.
Community Health Worker, because I love this. I love how this is just like it's creating like a standard for how, I don't know, but for how communities and counties can provide epilepsy care.
Right.
Yeah.
Right. And even just starting with the standard, the gold standard of care would be for any person with epilepsy to be seen by an epileptologist. That's the gold standard. That's what we want. And
Wouldn't that be amazing?
that would be so amazing.
Like, oh,
Yeah.
I know. Sorry.
And
It's like,
I mean, I'm sure you meet people all the time who are like, what's an epileptologist?
yeah.
Right. So that epileptologist is a neurologist who has an additional training in just epilepsy.
Mm-hmm.
So I'm not saying that a neurologist can't treat epilepsy. They have everything on the menu, and their goal would be seizure control. But an epileptologist, their goal is seizure freedom.
Mm-hmm.
And that's what we want. And in fact, as a woman, you are going to, if you are giving birth, you're going to go to an OB-GYN.
Mm-hmm.
You're not going to go to your internist.
Right.
You're going to go to a specialist. So if you have epilepsy, a very complex chronic disease, you're going to go to a specialist. So that's our gold standard. And so how do we expand the gold standard around the state? Well, the community health worker is such an important person in the entire sort of totem pole of public health. They are a person, so anybody can really become a community health worker. You just really need a high school degree, GED even. You can be trained. It's not a high paying job, but it's a high reward in terms of just the impact you have with people day to day. So if anyone feels like, oh, this is something I'd like to do, I'd like to be able to be a community health worker, we can get in touch.
Yeah. Well, sorry, and you're maybe about to explain this.
That's
and
okay.
I'm just like bursting with questions. I'm like, what does this mean? So what does a community health worker do? Like, who do they work for technically? And
So
what do they do?
in various places, you could work for a community-based organization, CBO. You could work for a health department. You could work for the state, really anyone. In the state of Illinois, currently, this program is not yet certified, which means I can't send a community health worker out and get reimbursed through Medicaid. So I would have to go to my local health department to work with a community health worker to get them trained in epilepsy so they can go out and do the work. So to kind of back up into what they do is they would be the people like at the laundromat holding up a flyer, like, do you have diabetes? Or do you know what high cholesterol is? Or do you know what epilepsy is? They are literally going door to door.
Wow.
Really just promoting health education.
Really grassroots. Like,
really grassroots.
Wow.
Yes. And so I would like to capitalize on their ability to be out there into the communities. And as I mentioned, 44 counties is a tall order.
Yeah.
So we were thinking of starting with 3 different counties. So if you can picture a map of Illinois, we have central Illinois, like from Chicago to central. So Greene County is all the way west. That's a county that we've identified we want to work in. Tazewell, which is just outside Peoria, excuse me, and McHenry County, way up north.
Yeah.
And we picked these counties to be a little intentional to see if there's any disparity in outcomes, if you're close to a health facility or not, specifically an epilepsy center or not.
Okay.
So I'm very curious to see if outcomes are different or similar.
So just so I understand, so the 3 counties that you chose, they all have different healthcare systems?
Correct.
So that we can compare
Correct.
what the outcome
Right.
looks like. Okay, got it.
So in Greene County, we're going to work with the health department. So they're not next to any epilepsy center. So who knows what we're going to find.
Yeah.
So I'm hoping we're going to find a lot of people who are like, oh, wow, I don't know who an epileptologist is, but my aunt has epilepsy and I'd love to connect her to care quicker.
Totally.
That's the goal. So the gold standard for our community health workers will be, number 1, do you have an epileptologist? And number 2, if not, why not? Kind of like, let's get you connected to someone. And then, of course, a bonus would be connecting them to the Epilepsy Foundation of Greater Chicago, where we can continue to offer free non-medical supportive care.
Totally. So, okay. So, but my question is like I don't mean to be the cynic here. I'm just curious about like the likelihood of being able to connect, like, because in some areas, epileptologists aren't even close by.
Exactly.
Right. So what does that look like for someone in, I think, Greene County, you said? Like, where do they go?
Yeah,
or
it's
what?
a great question. It's a great problem. So the beauty of COVID, the pandemic.
Like, you know what? We need more sentences that start with the beauty of COVID.
Is that telehealth is actually an option.
Yeah.
And actually can be reimbursed now through Medicaid. So, Because everything is, is it billable? Is it not? Unfortunately,
Well, that's the
that's
part
the world we live in.
Yeah.
Yeah.
And that's what we have to think about every time we go, before we go to anything.
Right.
Telehealth or not. Yeah.
Right. So that is the hope, is that we could connect someone through a telehealth appointment, at least a first visit. People can, if maybe someone already has a neurologist, go to an epileptologist for a second opinion. There is nothing wrong with getting a second opinion, maybe even a third opinion. I think our insurance system penalizes patients for looking for a second opinion, but I would encourage anyone and everyone to always seek a second opinion.
I agree with that 100%. And I think a lot of people feel who do have a neurologist and some people are even being seen by their internist, for epilepsy.
Yes.
And there's like this feeling of like being disloyal or something. And any doctor who is a good doctor will not be offended by a second opinion.
Correct.
And like, I think that's just something that like we need to like kind of move on from. And also like, I know it took me like, a long time to go get a second opinion just to see, but because of bandwidth, because of just like, I was just like, I am so exhausted from doctor's appointments. I can't imagine starting over.
Right.
And I think it's also about like, emotionally getting there, physically getting there, financially.
Sure.
You have to like get to a place where you're like, okay, here we go.
Right. But that experience put you in the driver's seat. You had all the agency to go seek that second opinion, to go make the decisions. Now you were able to decide between A or B.
Yes. And I'm very fortunate for that. Also because I live in Chicago. So like, it's not like the commute is that hard.
Yes.
Even though I can't drive, it's still I can get there.
Sure.
So I'm very fortunate.
Yeah.
Yeah.
Yeah. Yeah. And then Tazewell is next to Peoria, an epilepsy center, or nearby to Urbana-Champaign. So I would like to see if there's any disparities in outcomes that way. Disparities are just differences.
Right. That's awesome. And so the healthcare workers are now going to get training in epilepsy.
Yep. Yeah. Okay. I'll train them. And
of course you will.
Of course. Through epilepsy. And basically, it's not to make the community health worker an expert. I mean, anybody can be seizure first aid trained, and anybody should. And that's another thing that we can offer at the foundation for free. And we do that training so that people can recognize what a seizure is. Because I think that, as you know, and this is going to take a tangent, but the media has really shown us one type of seizure, the convulsive seizure, which is not even like 25% of all seizure types.
Right.
So let's have this education to talk about the other types, and then most importantly, what you can do to keep someone safe.
Totally. Yeah. I think it's almost getting to the point of like the common understanding of autism. And people will say there's a spectrum.
Right.
And I don't think people will say there's a spectrum of epilepsy.
But there is.
Exactly.
Yes.
Yeah.
100%.
And you and I know that because we're very ingrained in this world. But like, I think it's like, I would love to get to a point where, as a society, we are at least aware.
Yes.
Even though if we don't understand the spectrum, because it is understanding a lot.
Right.
But we just get that there is one.
Right.
Yeah.
And also, we just live in this increasingly no-touch society where a bystander might not help. It's really tough to see. And so I don't want people to feel alone or isolated. I want people to know that they can rely on others if others are educated and trained.
That would be nice. I did have a seizure on the L platform, which is like kind of, worst nightmare, right?
Yes.
Thank God mine are non-convulsive. And I often will sit before it happens. So like I was just sitting on the platform. It was like a cold February day.
Wow.
And I remember just sitting there, like, I don't remember sitting there, but I remember coming to and just watching, and it's rush hour because I was on my way to work. I was just watching all these feet just pass me by, and at the time I didn't think anything of it because I'm immediately postictal and not really, but later I was like, that's kind of weird that like not one person stopped. And sometimes I will stop when I see people and they're like, no, I'm fine. I'm just like having a moment. I'm like, real sorry about that.
Yeah. I'm just hyper aware.
Yeah, exactly.
Yeah.
But I've never even thought about that before. And I really appreciate bringing it up because like when I think, because up until this moment, I was like, well, it makes sense. I'm just a person sitting there, But maybe if there was more awareness, they would stop and think,
Yeah.
like, maybe she needs some help.
Yeah. And the worst someone will say is, no, I'm fine. And then they're not having a seizure because they're completely aware, maybe, or,
Right.
Yeah.
Totally.
Yeah.
Oh, that sounds awesome.
Yeah. 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 So it's a tall order. It's a really challenging job. I'm going to have high hopes and also very low expectations because we don't know. This is a pilot. So I don't know. And I'm really excited because this is such an iterative process. But I think that this can be so rewarding, just connecting people to care and giving them the education. And if nothing else, then at least I've dropped the seed of what epilepsy is in the community, and then they'll know where to go find more information.
Totally. I think that's wonderful.
Yes.
And so if someone wants to either, like, let's say they're in one of these counties or outside one of these counties, and they're like, I hear this, I want to be a part of this.
Yes.
What can they do?
Yeah. So in Illinois, there are a couple options. You can go to the Illinois Public Health Association, IPHA website, and you can find out information about becoming a CHW, the Illinois CHW website as well. And like I said earlier, they're still working on the certification process, but this is a good time to go through the schooling and the education and the certification process. Also, I just read recently Sinai Hospital. I don't know when I know this is going to be aired in September and we're filming in July. But Sinai is hosting a CHW program for people who are interested. So if someone is local, it's a free virtual program as well. But there's so many
virtual.
Yeah,
that's
right.
Again,
it's
just
great.
Makes things more easier, more tangible, accessible.
Exactly, and you can earn, let's just say, anywhere between $18 and $25 an hour, and it's grassroots work. So you could tack it on to something else if you're looking for part-time work, and it's so rewarding. We need more CHWs.
Oh, I love that.
Yes.
Okay. Well, I'll put all the information, all the websites you just mentioned in the episode description so people can go click on them.
Wonderful.
Figure out more.
Thank you.
Yes. No, thank you. Okay. And that's one, that's one project that Ayesha is heading. Like, I don't know how you have time to sleep. So the second one is so cool. Is so cool here in Chicago.
Yes.
And I feel like, and I know we're talking a lot about regional things, but I just feel like the what you're working on, including the next thing we're going to talk about, is a way. It's like a cutout or a model that can be applied after, like,
for sure.
After this comes to fruition, and
for sure.
Yeah.
So this is super exciting. This project. So back in 22 or so, I was stalking the Chicago Health Atlas website, as one does.
That's totally my rabbit hole. It's not Old Navy,
It's
app.
the Chicago Health Atlas.
Yeah, totally.
So I was on there, and of course, I was like, why isn't epilepsy on here? Why aren't seizures on here?
Wait, time out. So what atlas didn't have epilepsy?
The Chicago Health Atlas.
Okay.
So it will track, let's say, 30, 40 disease states, comorbidities. You could look up in what zip code has the most amount of asthma cases, or you could look up the truancy rates of certain age groups. I mean, you can get nitty gritty.
Okay, well, now this sounds kind of fun. Yeah.
It's like Wikipedia. Yeah. So I was looking, where is epilepsy, where is seizures, and nowhere to be found. And of course,
So wait, sorry, I'm so sorry. I'm just like blown away. So the truancy is on there, but not seizures.
No.
Or epilepsy.
No.
Okay.
Yeah. And this is the Chicago Health Atlas. So you're tracking on the health status of people in Chicago and suburban Cook County.
Mm-hmm.
So I put on my detective lenses and I started looking for who I needed to talk to. I met the chief executive officer of the Cook County Department of Public Health. I found him at a conference. I went right up to him.
You stalk him too?
I did. And I said, hi, I think you're missing some data on your website, and I'd love to talk to you more about how we can rectify that.
Mm-hmm. Yeah.
And so He said, well, that's great. It's probably just not on our radar. Let me connect you to our lead epidemiologist. We connected. We had a conversation. She wasn't really on board in the beginning. Then we agreed that she would do a look back on some old data that they could apply codes to. So
What does that mean?
So the billing codes, back to billing.
Oh, God.
Yep.
So that's how is that how it gets tracked?
That's
the
how it gets
Atlas
tracked.
is through, okay, so just for everyone who's not entirely sure what we're talking about, that's insurance codes, right? That get,
ICD codes.
yes, that get filed like when you go to the doctor's office, the doctor has to file certain codes. And so the codes are how...
It's an easy way to track where is something popping up, where is hypertension popping up, who's billing for it, et cetera.
Yeah.
So we have a medical advisory council through the foundation. It's a panel of 20 to 25 experts. And so one of the doctors from University of Chicago gave me a list of ICD codes. He said, use these. I gave them to CDPH.
Wait, okay, so you got the codes. Sorry, you're going to have to talk to me like I'm 5. So so you got the codes and then you went back
to the epidemiologist.
Okay.
I said, here are the codes. Please apply them to the look back data. Look back data just means it's just old. It's just sitting. It's not current.
Okay.
So anybody can use it to manipulate anything. So it was a test. Yeah, it was a test. And so months later, I remember I had come back to work right after the Boston Marathon and I was on such a high. And I opened my email and it says, Dear Ayesha, you were right. Look at all the disparities. And I said, well, yes, I know. So what we found was a significant disparity in the rate of emergency department usage in the south side of Chicago, like huge disparity. And that was basically the Ingalls Hospital, which is a safety net hospital. A safety net is basically it's just a community hospital. It doesn't really do advanced care. Okay. You just go because it's your local hospital.
Sure.
You wouldn't go there for cancer.
Okay.
So Ingalls Hospital was where multiple people were using the ED as their primary care. That's what we basically have come to determine with that data. As compared to, I looked at Austin Community, Evanston, Palos, like just looking around, you can go on the website and you can see epilepsy hospitalizations and epilepsy rate of visitation.
There's a disparity in epilepsy care specifically, that people are going to the emergency department or ER,
yes,
some people call it,
yes,
as their only way to get care for their epilepsy.
Yeah.
Oh, wow.
This is what we can deduce from that.
Okay.
So when we looked into this further, so then I went back to the doctor who gave me the data, and lo and behold, like within an hour, I was connected to the chief medical officer of Ingalls Hospital saying, this is a problem. We have to fix this.
Yeah.
And so we began this conversation, which started about a year ago. And where we are now is we're about to go for a site visit and we're about to meet with the team. I've met with the emergency department team just to kind of come up with an assessment of an understanding. Mm-hmm. I'm not trying to come in and tell anyone how to do their job, but I'm here as a team player.
Sure.
To see how is it that people keep coming for their 10th seizure, their 15th seizure. Why do they keep coming? Is it because they don't have a provider? They don't know how to use the ER. They don't have a rescue medication. They don't know seizure first aid. It could be all or any of those things.
Totally.
So the first part of this project is a listening tour to understand what the patient population is.
Wow. Okay, and just figure out what. And so like and I guess maybe you don't know this yet, but is it like people are getting their medications as well through like ER doctors? And then
so that's what we're not so sure about. There could be a disconnect because a lot of people, what we've learned, so I also have some additional data where I learned that most people are using the ER on a Monday for seizures.
Okay, so like waiting?
Could be waiting, could be a rough weekend.
Well, my husband is a firefighter in Chicago, right? And before he met me, he said that on Sundays they call it Seizure Sundays because they have so many seizures that they get called to.
Wow.
On Sundays. Yeah. And then once he met me and got a better understanding of epilepsy, he's like, I guess that makes sense just because, sleep can be a thing, and
Sure.
we don't always sleep as much on the weekend.
Sure.
Not blaming anyone,
Sure.
just like
It's a
triggers.
pattern. Yeah, it's a trigger.
Exactly.
Right.
So Mondays, interesting.
Yeah.
Okay.
So yeah, I'd love to, and of course, there's no CHW assigned to epilepsy there because it's not a thing. It's not something that really has been made yet very common. So, as you said, I'm hoping that this is going to be a model for what we can do in different places. Because imagine you had a patient who came in on a Monday, they had their seizure, they were being discharged, but before they were discharged, they were funneled through a CHW who was assigned to them and said, okay, well, who's your epileptologist? And then you learn either they have one, then they need to have a follow-up appointment, or they don't have one. They've never heard of one.
Yeah.
So you can that's a education moment right there.
Sure. And then, like, as an education moment, does it also lead to an actionable?
Yes.
Okay.
Yes, because if they had an epileptologist, then this was a breakthrough seizure. Let's figure out what that breakthrough was caused by. If they don't have an epileptologist, then let's get you one. And now Ingalls Hospital actually has just been bought by University of Chicago, so they're building out an epilepsy outpatient center there, so we can get connected to an advanced specialist right there.
They're building out an epilepsy patient center? That's fantastic.
Yes. Yeah.
Is it the only one in Chicago?
Well, outside of the Hyde Park location. So
Right.
then they're moving. They have now their space that they're taking over in Ingalls. Yeah.
Okay.
Yeah.
Wow.
Yeah. So
Oh
it's
my
a big
gosh,
deal.
That is a big deal.
So we need to connect people to care quicker. We need to do patient education on how to use the ER in general.
Totally. I mean, and I think that's one of those things too. It's like, I remember that learning curve when I was diagnosed with epilepsy, figuring out, because I think that's part of it. In the very beginning, it was like, I'd call my doctor after every seizure, or sometimes go to the ER because I just didn't know what to do, until like you kind of figure out the rhythm.
Sure.
And I'm just wondering how many people like just still haven't been able to figure out the rhythm.
Yes. Well, let me throw another wrench into this.
Oh, let's do it.
Yeah. So what I also learned about the patient population is that a lot of them are TBI, so traumatic brain injury victims.
Oh.
And so for epilepsy, it might take up to 20 years to show up as epilepsy for a TBI.
Yeah.
So
Great.
that initial injury moment might not even materialize to something so it's so hard to longitudinally track. So that's why we have no gold standards, because we're not able to really track things properly, like from a public health perspective, like to get really good data.
Totally. Yeah. I mean, that's something I, just in my own little sphere forget, just because mine was TBI, but it was like 3 months later, or not even 6 weeks later or something. So it was very clear, like what caused it. But I always forget that there's that huge span. And I've had guests on too who've talked about that. They're like, especially veterans.
Oh, yes. Yes.
And they're just like, it doesn't hit them until much later. And then it's like this game of trying to figure out where this came from. And it seems so odd that like 20 years later, this could be the outcome.
And then what does someone do 20 years later? Like, are they going to go back to the ER? Are they going to call an epileptologist?
Right.
Are they going to just talk to their GP?
Yeah.
Probably just do what's easiest.
Yeah, totally.
Yep.
So the goal is that when this person is getting discharged, it's like, do you have an epileptologist?
Right.
Do you not have an epileptologist? Are there any other actionable things that we're hoping to like send them off with, or?
Well, if they leave the ER and it's a proper diagnosis of, so here's another wrench. In the ER, there is not, an EEG is actually not one of the bread and butter screenings.
Oh my God, I never thought about that.
Yeah.
Because I've never had an EEG in the ER.
Because it's not even on the menu.
Not there.
Yeah. Yeah. They'll do a CT, they'll do an MRI,
Yes.
but when do they do an EEG? They don't.
Wow.
So I read a study somewhere, and I feel bad even mentioning it because I can't source it, but I know I read a study at some point that
I believe you.
that said in LA, that's, if they were able to do an EEG, like at least 70% of people would be caught, like in terms of making a diagnosis of epilepsy. And I thought that was so just outstanding that's what we're missing.
Yeah.
If everything goes well in the ER, and I know I use ER and ED interchangeably, but it's the same thing, emergency room, emergency department.
Well, I've noticed like ED is the new-ish term. At least I've noticed with like my healthcare providers.
Yeah, because it's more of an institution, the emergency department.
Totally. Yeah. And I think, but sometimes I've also noticed when I say ED, like not everyone knows what I'm talking about. So I always just say ER.
Yeah.
Like, it's a room. Yeah. It's just a room.
It's just a room. Yeah. It's just an experience. But assuming everything goes well in the ED and the person who's being discharged has a proper diagnosis of epilepsy, that actionable moment would be connecting them to an epileptologist with the next step. So like now we have the ability to do really rich electronic health records with QR codes, with data, with information, patient follow through. A lot of patient follow through is called the Epilepsy Foundation to be connected to community, because community is probably the first thing they're going to want to do is what do I do with this new diagnosis?
Yeah.
Where do I go?
Yeah.
So we want them to be connected to the foundation for sure.
Totally. Because the foundation does have amazing connection, partnership, all of those things. Like I think it's just such a well-rounded institution that you guys got running over there.
Thank you.
Yeah. And I don't know if you want to speak to some of the opportunities that EFGC offers.
Sure. We are in the summer season, so camps, like camps for kids. I think it's like sometimes it's the first time parents can drop off their children and be completely relieved that, okay, they are with other kids who are walking in the same shoes and I'm good. I can go to the mall for a few hours, or I can have an overnight to myself. It's just a wonderful bonding experience for children. And also for adults, we have great programming. The architectural tours, art therapy is something we're bringing back. That's
awesome.
Art therapy is great.
That was what I wanted to be when I went to college. I wanted to be an art therapist. And then my college advisor was like, well, you have to get a degree in psychology, which involves taking biology. And I was like, nope.
Oh, that was the weed out.
I don't have that brain. Yeah, but I'm a big fan of art therapy. I think it's amazing.
Yeah, and then we have like our annual summer picnic. It's a game at the Dogs in August. And then we have our 5K walks coming up, which are huge family events. We have the one in September on the 20th in Wheaton.
Yes.
The big Cantini Park. Have you been there?
Not in a long time. I usually say the one in Chicago.
Okay, so the Montrose one, that will be in the 2 Saturdays after that. I think it's October 6th, Montrose Harbor.
Yeah. Yeah. Which is amazing.
Yeah. They're both really great. And it's community. Exactly. Yeah. It's just, I brought my husband to the Springfest one, and he hadn't, I've been at the foundation almost 14 years. And so he came to a lot of things in the beginning and then took a break. And now he came out again, and he's like, wow, this is like such a great community. So for someone who's a complete outsider, for him to be able to watch the magic was really nice.
That's cool to hear, because I know like when I showed up to the first one that I went to, with epilepsy, because I went to a few prior to that because epilepsy runs in my family. So I'd gone as, someone who loves someone with epilepsy. And then when I showed up with epilepsy, I was just like, I didn't know anyone there. And I just felt like it was a hug just walking in.
Wow.
Oh,
that's good.
Yeah. And so it's cool though that like someone, like your husband also feels that magic.
Yes.
Yeah.
Yes. Yeah.
Yeah.
Yeah. And then just going further down the calendar, I can tell you more. I mean, my annual conference, which I know you've been a part of, the annual education conference, November 15th. And that's just such a fun day of learning. Mm-hmm. It's a lot of work on my end, but I love every moment of it. Putting together these awesome panels on surgery, health equity, pipeline medications. We talk about coexisting diseases. So lots of times people with epilepsy have mild to moderate depression, anxiety, learning disorders, or other things that are happening.
Comorbidities are
That's the
a laundry list.
A laundry list.
Yeah.
So, I think we would be remiss if we don't talk about them.
Mm-hmm.
So it's a really great day. So that's Saturday, November 15th. So
So awesome.
yeah,
That's so great.
Lots of things happening.
Yeah, absolutely. And the one program, though, that I also want to point out to people who are in, the 44 counties of EFGC is the case management program, because I feel like that is huge. And that one-on-one guidance and help.
Yeah.
Like, oh my gosh.
Yeah. And and
it's free.
And it's
like,
free.
can we talk about how all this stuff is free? There's also, but we do have to plug, though, the fundraiser to help make these things free. Casino night.
That's you.
Yes.
It's your department.
Yeah. You're like, that's on you.
Board. Yeah.
Yeah. Also in November, which is a really fun night.
Same day.
Yeah. Yes. I thought so. I was like, I think it's November 15th as well. Yeah. But so like just to keep these things free.
It's amazing.
Yeah.
Yeah.
Okay. But this case management program, if we could just talk a little bit about that, just in case there's someone listening who could benefit from it.
Absolutely. So outside of our free education that we do for schools and communities as part of the Seizure Smart School Act, the case management and clinical program really are like the hand in hand, the partnership with the person living with epilepsy. And I'll give you an example. Years ago, I sat in on an IEP meeting with one of the case managers at a school. Mm-hmm. The IEP meeting was for a 6-year-old. And they were at this juncture because he was just not progressing in school. Like they couldn't figure out what was going on. So they also invited me to come in from an education perspective to see what was going on. As we were reading the notes, we learned that the student was on an adult dose of some medication. And it was just causing him to have brain fog every day. It was like Groundhog Day. He could not remember anything, couldn't figure anything out. They changed his dosage, and then within a certain amount of time, he was a normal 6-year-old. It was great. Wow. But that's the kind of IEP help and support that our case management can provide. Mm-hmm. Sometimes someone comes in because they need help filling out a form, as simple as that. Help me fill out a CTA travel form to get reduced travel. Yep. Yeah, we got you.
Yeah. 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 I mean, as soon as you start talking about paperwork help, it's like in.
Yeah.
Yeah. Because it's so hard to navigate.
Tough. It is tough. Yeah. Yeah. So we are really proud of our case management program. And that's something that people can partake in virtually as well. Mm-hmm.
Yeah.
And the support groups.
Yes. The list is never ending.
Yeah.
It's amazing.
There's a lot.
It's amazing.
There's a lot.
Well, I really appreciate all the work you do.
Thank you.
And I really appreciate you being here.
Thank you.
But before we wrap up, I'm going to ask you 3 questions that have absolutely nothing to do with what we've been talking about.
Oh, fun.
So, total change of subject. Okay. First one I think is a little easier. Number 1, what's your favorite color?
Black.
What? Lately, so many guests have been saying black.
I don't know.
And it's usually very, very smart people.
Oh, wow. Okay. Black with a little glitter? No, black.
Yeah. Yeah. Okay. But isn't black all the colors, or is that white? I see this is smart
you're
person.
Right. Yeah, so you should have the art school program.
Yeah. Right. Okay, number 2, if you could have lunch or just a casual conversation with anyone that are alive, who would you choose and why?
Dr. Paul Farmer.
Okay.
Before I was in public health, I was, believe it or not, a tax accountant.
That does make sense because you're very on it. And as a tax accountant,
you kind of need to.
Yeah.
So, I come from a family of physicians, and I just knew I didn't want to do medicine. Mm-hmm. So I chose accounting. Read the book, The Alchemist, which was not written by him, but that was life-changing.
Agreed.
Yes. And then I started learning about public health and found Paul Farmer, who he is Mr. or Dr. Healthcare is a human right. Everything he did was healthcare is a human right.
Wow.
So and he died, unfortunately, a few years ago. Very young.
Oh, wow.
Yep.
Okay. Of course, that would be your person.
Yes.
Now I want to have lunch with him too. And third question, what does it mean to you to be a friend?
Oh, Loyalty is the first word that comes up. To be loyal, to be there, and to just stand right next to someone, and be not behind them, not in front of them, but right next to them.
Oh, I love that.
Yeah,
Yeah. Just shoulder to shoulder.
shoulder to shoulder.
Right here.
Yeah, yeah,
That's really beautiful.
yeah. Thank you.
Well, thank you so much
Thank
for being here.
you.
I really appreciate it.
This is great.
I can't wait to just track this work
Me
that
too.
you're doing and report back to everyone, and so we can start using it as models.
I hope
you
so.
know?
Yeah, let's go out there, do some great work.
Absolutely.
Thank you.
Thank you, Ayesha.
Thank you.